Chapter 33, Obstetrics and Neonatal Care. Very exciting chapter. Let's jump right in. National EMS Education Standard Competencies that nobody really cares about. I mean, obviously I care about, and this is what we're teaching to, and they matter to all of us. Our intro. Deliveries occur in the hospital. Occasionally, the pregnant woman is unable to get to the hospital. We need to decide whether we stay or should we go now. Isn't that a Ramon song? I mean, I could sing it to you, but you don't want me to do that. You're welcome. So our anatomy and physiology, this stuff we all know. Oh man, if we're in person, I'd make some sort of rude comment about certain members of the class not having any idea what these items are. But for the rest of us, ovaries are glands, one on each side of the uterus. They're what makes the whole thing when you look at a picture of the vagina, uterus, ovaries. It looks like the ram's horns or a skeleton skull with horns, which is exactly what it is. Similar function to the male's testes. Thousands of eggs. The eggs are there. They're all there. Like semen is produced at an ongoing rate. The eggs are all present. And they drop about 2 weeks prior to menstruation. So for 2 weeks, the female is fertile. Fallopian tubes connect from the ovary to the who's who, what's it. I could do this. I can't do it. I'm tired. Oh, I'm sorry. How unprofessional. So, fertilization, when the sperm meets the egg inside the fallopian tube. Fertilized egg continues to the uterus, where, if implantation occurs, it develops into an embryo, and then a fetus, and then a little monster. Uterus is a muscular organ, encloses and protects the developing fetus as it grows for approximately 9 months. Contractions are the muscles squeezing, trying to get the monster out, to push the baby through the birth canal. Birth canal is made up of the vagina and the lower third of the uterus, called the cervix. There's a picture of a baby in birthing position. The vagina is the outermost cavity of the female reproductive. Yeah, it's the outside part, the part we could see and feel. Oh, if only this wasn't being recorded for public access on YouTube. Completes the passageway from the uterus to the outside world. It's the baby superhighway. Perineum is the area of skin between the vagina and the anus. This is where the tearing tends to happen when the baby's head is protruding and the opening just isn't quite wide enough. Breasts produce milk, and they're carried through ducts to the nipple. Yeah, you know this. Early signs of pregnancy in the breast, including that they get bigger and tender. So even though they're bigger and inviting, you're not allowed to touch them. I mean, of course, if it's, say, your wife, and in general, you'd be allowed to touch them. Yeah, not now. They're not fun bags at this point. Placenta attaches to the uterine wall and connects to the fetus by the umbilical cord. So the placenta is often about the size of, like, the baby, or at least half of it. And it is feeding the baby with everything it needs. The placenta is connected to the baby with the umbilical cord. Anything that enters the woman's body is going to enter the baby's body. We need to be aware of that. When treating a pregnant patient, we need to factor in the fact that anything they've done is going to affect their unborn child. After delivery, the placenta separates from the uterus and delivers, generally between 5 and 35 minutes after the baby is born. The placenta will come out. Umbilical vein carries oxygenated blood from the placenta to the fetus. So here's a situation where the vein is carrying the oxygenated blood. Umbilical arteries carry deoxygenated blood from the fetus to the placenta. Fetus develops inside a fluid-filled bag-like membrane, 500 to 1,000 milliliters of amniotic fluid. I believe sometimes it could be a little bit more. Once those bags of waters break, it will appear to be a lot more. It will seem like 5,000 milliliters of fluid. They just leak and leak and leak. A lot of times the ambulance will be called at that point because Dad doesn't want his new car to get this stuff on the seats. And rightfully so. I mean, garbage bags could only do so much. Yes, you put the wife in the garbage bag so that the fluids are collected. No, you put them on the seats. But that's not our problem. We have a nice vinyl stretcher that they could leak all they want and you can mop it up later. It does start as a gush and then it turns into a river, a stream. I first was thinking trickle, but it tends to be a little bit more than a trickle. Normal changes occur in the body that are not all directly related to the reproductive system. Respiratory, the female's going to breathe faster, heart's going to pump more, musculoskeletal changes. During birth, the pelvis splits in two so that the baby will actually fit out. Hormones go crazy. The uterus grows as the baby grows. As the size, so does the amount of fluid it contains. Uterus and organs are shifted from their normal position. The baby's feet will inevitably end up in the bladder. Second trimester is our most busy season for growth. Displaces the diaphragm, makes it harder for the woman to breathe, makes her life miserable. Towards the end of the second trimester is when she really starts to whine and complain constantly, and her feet hurt. She has to pee again, and she can't breathe, she can't breathe. Respiratory capacity changes with increased respiratory rates and decreased minute volumes. So the lungs cannot expand as much as they used to because they're being compressed. Blood volume increases. I mean, it could grow by 20-30%. It's amazing how much blood a pregnant woman has rushing through her veins and arteries. Prepare for the blood loss during childbirth. That has a lot to do with it. The female is going to lose blood during childbirth, no way around it. And the body knows that, so it prepares. Clotting factors also increase, and the heart rate will increase up to 20%. So a woman whose normal resting heart rate is 70 will go up to 100. Third trimester, an increased risk of vomiting and potential aspiration following trauma. So first trimester, is the morning and or all day sickness where mom just randomly vomits just because it's fun, apparently. But the third trimester, when there's trauma, the chance of vomiting is increased more than most people who suffer trauma. And a lot of it has to do with the new position of the stomach and the fact that all those miles of small and large intestines are being compressed. So lots of changes in cardiovascular system. The fetus causes an increased workload. The heart has to work harder the whole time. Women that are not healthy when they begin are going to have more risk of compromise. And cardiac compromise is a life-threatening possibility. Weight gain is normal. You want them to weight gain. The joints become looser and less stable, more likely to suffer injury, especially for the older or less physically fit. Body center of gravity changes drastically. Balance is not maintained like it once was. Most pregnant women are healthy. Welcome to America. I love that statement. Some may be ill when they conceive or become ill during pregnancy. I mean, thanks, Captain Obvious. You rear your ugly head again. Oxygen to treat any heart or lung disease in a pregnant patient. We use oxygen to treat any heart or lung disease, right? Right. Diabetes, gestational diabetes, is when a woman gets diabetes just for the pregnancy and then it goes away afterwards. During the gestational diabetic period, their treatment from their doctor is going to be the same as any other diabetes. The wonderful thing about it is that it tends to just go away once they deliver the baby. Preeclampsia is an issue, can develop after the 20th week. Signs include severe hypertension, persistent headache because of the hypertension, visual abnormalities, again, because of the additional pressure upon the eyes from the hypertension, swelling in the hands and feet, and the anxiety is a byproduct of all those other signs and symptoms. Preeclampsia will develop into eclampsia. Eclampsia is deadly for the mom and the baby. Seizures that result from the hypertension. So preeclampsia is the cause of eclampsia. Preeclampsia is the increased hypertension. The eclampsia is once it progresses to seizure activity. Left side, maintain airway, give oxygen, suction the airway, rapid transport, and paramedic intercept. Hopefully any patient getting prenatal care from a qualified doctor person is going to recognize the preeclampsia and not progress to the eclamptic state. Transporting the patient on her left side will stop the hypotensive syndrome. That is from the weight of the baby compressing this inferior vena cava, which we don't want. So we either need to elevate the hips on pillows to displace the uterus or transport them on their side. This is a fairly big concern and very easy to manage, so let's manage it. Internal bleeding, ectopic pregnancy. So this is when the egg gets fertilized and then implants in the fallopian tube itself. The fallopian tube isn't meant to stretch and get bigger like the uterus. So generally, still in the first trimester, it'll get big enough where the embryo bursts the fallopian tube and severe abdominal pain happens. We talked about this in abdominal pain class. Talked about it a lot. Female of birthing age range with abdominal pain. It's one of the things we need to suspect. Internal hemorrhage following the rupture of an ectopic pregnancy. This is a serious concern. Some of that blood should be leaking out. Remember that the uterus and the pelvic cavity as a whole could hold a lot of blood. We need to question our patient as to their menstrual cycle, if they've missed any, if there's any possibility of being pregnant. Lower abdominal pain, we need to really have a high level of suspicion for this. Spontaneous abortion, we like to call miscarriage because for whatever reason, most people think it sounds less horrific. Abrupto placenta, the placenta separates prematurely from the wall of the uterus. That is definitely a problem. Massive bleeding for mom, death for baby, definitely a problem. Placenta previa, the placenta develops over the cover and covers the cervix. So this means that the baby will not be able to have a natural birth. Um, this is not a situation that you want to find yourself in. If it looks like it's probably or possibly going to be a on-scene birth, and you to inspect for cervical dilation, and instead of seeing hair, you see something that looks more like brains, that is most likely the placenta. In a placenta previa situation, if this patient has proper prenatal care, they will know, she will know, the family will be able to tell you, there's no chance of you delivering on scene, you need to get her to a hospital. If she's had no prenatal care, possibly the teenager who's been claiming she's just getting fat because she doesn't want to tell the family she's pregnant, then you might not know, and that will be a problem. So there's some pictures of it. An abortion is the passage of the fetus and placenta before 20 weeks. So anything prior to 20 weeks is considered not viable and therefore an abortion. Spontaneous means it just happens on itself. Induced means that something was done to cause it. Happens in a controlled environment, the baby might actually be able to survive. The most serious complications for spontaneous abortion is bleeding. For us, it's bleeding. For the patient later, it's infection. Treat and transport promptly and treat for shock. Treat for shock, treat for shock. Pregnant women have an increased chance of being victims of domestic violence and abuse. That is not something we should be able to say, but I'm not here to get political. But it's a sickening thought, isn't it? Abuse will cause an increased chance of abortion, premature delivery, and low birth weights. Woman is at risk of bleeding from infection, uterine rupture. Calm professional approach is important. Pay attention to the environment for signs of abuse. Talk to the patient in a private area away from the potential abuser if possible. We'll go over signs of abuse when we deal with abuse in at-risk populations. Addiction definitely affects the fetus. Premature birth, low birth weights, respiratory distress on birth, death, signs of withdrawals shortly after birth. Fetal alcohol syndrome describes the condition of infants born to women who have abused alcohol. Fetal alcohol syndrome is its own class, but it's definitely an issue. Most of these women that are alcoholics are not getting proper prenatal care. Special attention to your safety. A truly addicted patient will oftentimes be more concerned about feeding the addiction than caring for the baby in their womb. Eye protection and face mask. You need to have a high level of suspicion that these patients have some sort of infectious disease. Look for clues that you are dealing with an addicted patient. Your heroin use, you're looking for track marks. Methamphetamines and narcotics, you're looking for rotten teeth. Remember meth mouth? And the signs of alcoholism and smoking and all that happy nonsense. And the newborn will need help. These babies do not come out fit for duty. They come out in need of a lot of help. Trauma in pregnancy. Nobody wants to see a traumatic situation for a pregnant woman. And remember that you do have two patients in these situations. Trauma to a pregnant woman may have a direct effect on the fetus. It most likely will. Assaults, motor vehicle crashes, shootings are all severely complicated by being pregnant. And they're more likely to fall down and go boom. So they have about a third more of their total blood volume and 20% increase in their heart rate. So they could lose a lot of blood before they show any signs of shock. Obviously, the uterus is vulnerable to penetrating trauma and baseball bats. So we need to have a high index of suspicion of fetus damage in those situations. So a lot of times, the big issue with MVCs and the pregnant lady is that the seatbelt wasn't worn properly. They need to be very vigilant at getting that seatbelt down below the fetus, and sometimes it doesn't work out that way, or they shift during the crash. Vaginal bleeding and severe abdominal pain are what you're most likely going to see. Abruptio placenta, the separation of the placenta from the uterine wall, is our biggest concern, and that should be a painful experience. So the mom who suffers it should be complaining of a lot of abdominal pain. I'm sorry, it's a yawning type day. The mom who's just terrified that there might be an injury won't have any abdominal pain, but will just be terrified and want to go to the hospital. By all means, encourage them to do so. So this is what we said. Cardiac arrest is the same deal, except now you're trying to save 2 lives. Notify the receiving hospital early that your patient is a traumatic arrest and pregnant. They're going to want to know that. Focus on the mom. Suspect shock dependent on the mechanism of injury. Be prepared for vomiting and aspiration. Attempt to determine the gestational age to assist you in determining the size of the fetus and position of the uterus. So you want to know how many weeks mom is. Follow these guidelines. Open airway, high flow oxygen, adequate ventilation. Check the circulation, support it if it's not present, and transport on her side. If you have to keep the mom supine, then make sure you elevate the hips. Put a pillow or 2 under them, and it'll get the weight of the baby off of the vena cava. Cultural sensitivity. Some cultures may have a value system that will affect the choice of how they care for themselves during pregnancy, how they plan to have the baby, whether or not a man could do anything for the patient at all, and you need to honor their requests. A competent, rational adult has the right to refuse all or any part of your assessment or care. There's a chance that a man might not be allowed to care for her. It might be a situation where you have to let the patient's mom ride with you in the back of the ambulance, and you need to just sit in the captain's chair, cross your fingers, and hope she doesn't die. Teenage pregnancy rates are huge in America. Again, teens will deny it. They certainly will deny it if mom and dad are around. You need to respect their privacy. You need to try to get them away from their parents and interview them somewhere where you could assure them that nobody but you and the doctor at the hospital is going to know what they say. Childbirth is rarely unexpected. Dispatcher should give you a clue how likely it is that birthing will have to happen on scene. Premature contractions can be caused by all kinds of things. Standard precautions, gloves, eye and face protection are the minimum. If you can, put on a gown. Generally, the OB kits have a gown. Consider asking for additional help. Remember, if everything goes well or not, you're going to end up with 2 patients. You need to have enough hands to deal with 2 patients. Encounter pregnant patients who are not in labor, so it is important to determine the mechanism of injury or the nature of illness. Do not develop tunnel vision. Falls and necessity for spinal immobilization must be considered. Good luck getting a pregnant woman to lay on a backboard. It's not going to happen. It's not good for them. So you need to think a little bit outside the box on that. General impression, patient in active labor, whether you have time to assess and address other possible life threats, or you really need to address them while you're driving down the road. Rapid exam. Evaluate the acute traumatic injuries or current medical problems first. Airway. Life-threatening conditions with the woman's airway and breathing are usually not an issue during a birth. No, it's not. But they are definitely an issue during a traumatic event or other medical situations. MVC, assault, medical condition may cause a life threat. Thank you for that. Assess airway and breathing. Assist it if not adequate. External and internal bleeding are potential life threats for everyone, especially the pregnant woman. Blood loss after delivery is expected, but significant bleeding is not. The problem is, how do we, the layperson, yes, we're trained medical professionals, but when it comes to childbirthing, we're lay people. How do we know how much blood is acceptable? A lot of it's going to have to do with the vital signs. And try to treat as best you can. We obviously cannot pack the uterus full of quick clot, but we can massage the uterus and especially reach for the back wall. We could have baby go right to nursing, all things that'll help control the bleeding. And keep a close eye on skin color, temperature, moisture, and pulse rate, quality, and rhythm. If delivery is imminent, mom is already 10 centimeters, the baby's head is visible, we need to prepare to deliver there. Ideal place to deliver is in the ambulance or the woman's home. I would not call the back of an ambulance an ideal place to deliver. You're much better in the house. If it's not imminent, get them to the hospital before it becomes imminent. Rapid transport for anybody with significant bleeding or pain, hypertensive, actively seizing, or altered mental status. These are not things you can manage on scene. Obstetric history is important. Expected due date, very important. Complications that she knows of, whether or not she's getting prenatal care, and her past medical history. These things matter. We want to know. Pertinent history specifically to prenatal care, please. Due date, frequency of contractions, history of previous pregnancies and deliveries, possibility of multiples, or their history of twins. As your doctor said, you're having twins. And if she's taken any drugs or medications. Remember, drugs are for fun, medications are from a doctor. If her water is broken and whether the fluid was clear, it's sort of opaque, or green, meaning that there's meconium or baby poop in that fluid. If the baby's pooping inside the mama, then there is distress. Assess the major body systems as needed. Focus on the chief complaint. Assess for fetal movement, which is simple. You press down on the baby and see if it's moving. Check for crowning if you think it's imminent. So vital signs. They're all our normal vital signs. The big thing is to be alert for hypotension or hypertension, and realize that hypertension could be preeclampsia and the sign of a serious problem. Repeat your assessments. Additional sets of vitals. Confirm that your interventions are having a positive effect. Whatever you could do to keep everything viable if there's traumatic injury. Notify the hospital early. They're probably going to have you go directly to the OB department. At Charlotte, it's the 3rd floor. I believe at Sharon, it's the 2nd. It's the 2nd floor. But it's like way back and far away from the ED. Update on the status of the woman and newborn after delivery. Call in prior to delivery if you can, if delivery is going to happen at the scene. If you're on scene trying for more than 30 minutes, you should get moving. So if you're transporting a pregnant female for some basic medical condition or traumatic injury, you want to make sure that you include that she's pregnant in your patch and all the important stuff from her pregnancy. How many weeks along, what her due date is, and any known complications. If you deliver prior to the hospital, you have to report on 2 patients. The 3 stages of labor: dilation, delivery, and delivery of placenta. So the first stage is from the first couple of contractions through the cervix being 10 centimeters or fully dilated. The second is from full dilation through the complete delivery of the baby. And the third stage is from the baby coming into the world to the placenta entering the world. Now, the first stage begins with the onset of contractions until it's fully dilated, usually the longest lasting up to 16 hours. Uterine contractions become more regular and last about 30 to 60 seconds each. Throughout this time, the frequency and intensity increase. Remember, we time contractions from the start of a contraction to the start of the next contraction. Primi gravida, first pregnancy, then second and other pregnancies. The first one always takes the longest. False labor is called Braxton-Hicks contractions. They could start towards the beginning of the 3rd trimester. It generally makes the mom, especially the first-time mother, very anxious, freaking out that they're going into premature labor. And again, provide transport, keep the patient calm. Differences between Braxton-Hicks and true labor. Certainly not something you need to know for testing purposes, but it might be handy if you retain any of this moving through your career as an EMT. Premature rupture of the amniotic sac could be a bit of a concern. May or may not go into labor. Provide supportive care and transport. The head of the fetus descends into the woman's pelvis as it positions for delivery. The descent is called lightening. This is the very first stage of labor. Second stage, the fetus begins to encounter the birth canal. It's starting to press in there. Ends with the newborn being born. Second stage. Ends with the newborn being born. Uterine contractions are normally, you're 1 to 2 minutes apart. Towards the beginning of the second stage, they're probably 5 or 10 minutes apart. And they're going to be long and intense and get longer and more intense as they get closer together and you get towards the end of the second stage. The perineum will bulge significantly as the top of the head appears in the vaginal canal, and this is called crowning, when you see the crown of the head. Third stage, once the baby's out, and ends when the placenta is completely out. 30 minutes is a pretty fair timeline. Delivery is imminent. Baby's already crowning. You think it's pretty close to coming out. then you want to consider doing it where you are. Natural disaster, inclement weather, other environmental factor that make it impossible to reach the hospital. You might not have a choice. Ask the following questions. How long have you been pregnant? When are you due? Is this your first or second baby? Are you having contractions? How long have you been having contractions? How far apart are they? How long do they last? Have you had any spotting or bleeding? Has your water broken? Do you feel as though you need to have a bowel movement? Well, guess what? When they really start to press and push, they're going to have a bowel movement. And do you feel the need to push? Potential complications. How was your previous deliveries? C-section? Well, if the first one was a C-section, then the rest are probably going to be C-sections. Any problems in this or previous pregnancies? Do you use drugs, alcohol, or take medications? Is there a chance of multiple deliveries? Nobody wants to deal with that on scene. And did your doctor say, hey, you're going to have a complicated pregnancy and delivery? If the patient says she's about to deliver, she has to move her bowels, or feels the need to push, you should prepare for delivery. Does she have an extremely firm abdomen? Visually inspect the vagina to check for crowning. Yeah, I don't care who you are. If you show up, you need to look. Once it begins, that's it. It's happening. Never attempt to hold the patient's legs together. Don't let her go to the bathroom, because she'll probably drop the baby in the toilet. If you deliver at the scene, you have two patients. You are only assisting the woman. She is delivering. You are not. You're playing catcher. Your emergency vehicle should be equipped with 2 OB kits. Try to preserve their privacy. Most women in labor don't care so much about their privacy. Firm surface, elevate the hips, support the head, neck, and upper back. Have her keep her legs and hips flexed and her feet flat with the knees spread apart. Preparing the delivery field. I love that. Place towels or sheets on the floor around the delivery area. It's going to be messy. Open the OB kit. Don't spill everything on the floor, please. The sterile gloves in the kit are what you're supposed to use. Sterile sheets and drapes from the OB kit to make a sterile delivery field. There you go. There's a good position. Your partner should be at the head. Comfort, soothe, reassure. The husband, family should be at the head to do all those things. Check for crowning. Make sure you could see the perineal area at all times. You need to be looking down there to see what's happening. Time the contractions. Quick, short breaths during each contraction, but not to strain. And between contractions, remind the patient to breathe deeply, to try to relax. As the head exits the vagina, you're going to support it with your gloved hand and let it rotate. It needs to rotate. Gentle pressure across the perineum. Sterile gauze pad to try to reduce the risk of tearing. Chances are it's going to tear. There's nothing you can do about it. Be prepared for the possibility of a bowel movement. It's a very real and likely possibility. Don't poke your fingers into the fontanelles, the soft spots of the skull. You don't want to cause brain damage. Be very gentle with its head. If the amniotic sac does not rupture on its own, you will see the fluid-filled sac emerging with the baby. It could suffocate the fetus, so you have to puncture it. Generally, just your fingers twisting it a little bit will rip it right open. Once the baby's out, clear the mouth and nose immediately. Mouth first, nose second. I'm thinking here. I always forget. Did I tell you that right? Hold on. Yeah, mouth and then nose. Once you suck out the nose, that should stimulate the baby to take its first breath. Feel whether the umbilical cord is wrapped around the neck. If it is, you need to get your fingers in there. Usually you could slip the cord gently over the delivered head. Usually. If not, you must cut it. Once the cord is cut, attempt to speed delivery. If you can get it over the head, do that. That's a much better option. Delivering the body. Once the head is born, the body usually delivers easily. Yeah, it does. It sort of rotates to the side and just slips right out. It is the head that is a nightmare to get out. Support the head and upper body. Do not pull it from the birth canal. The newborn will be slippery and covered in cottage cheese. Covered in vernix caseosa. It looks like cottage cheese. If the mother is able and willing, place the newborn on her abdomen so skin-to-skin contact could begin immediately. Dry off the newborn, wrap him and her in a blanket or towel. Wrap the newborn so only the face is exposed. That's called swaddling. Pick up and cradle the newborn. Keep the newborn at the level of the woman's vagina until the umbilical cord is cut. That's very important. If you hold the baby above the level of mom, all the fluid from the baby will drain back into mom, and that baby needs to stay in it. Once the cord has stopped pulsing, clamp and cut the cord. Obtain the 1-minute APGAR score. Delivery of the placenta. Your job is to assist. It will deliver itself. It will fall out. And never pull on the end of the umbilical cord. You do not want any of that to break and stay in mom. If a piece of the placenta stays attached to the uterine wall, it's like an open I don't know what I'm going with, but it's a place for bleeding to continue, and it's very dangerous. APGAR score, you should see that in your book. You should know the APGAR score for testing purposes. And then you could pretty much forget it until you need it in a real life situation. So gently massaging, that's what I thought. And a doctor has advised me that you really need to reach in there and massage the back wall of the uterus where the placenta was attached. So you need to press. And remember, there's a lot of flub and flab in there now that baby's gone. There's extra fat tissue. You got to reach through all that and massage the posterior wall of the uterus. Definitely record the time of birth. People are going to want to know that. Following emergency situations. More than 30 minutes without the placenta delivering. More than 500 milliliters of blood before the placenta delivers. Significant bleeding after delivery of the placenta. These are signs of problems. Standard precautions, gloves before handling the newborn. Usually the baby will begin breathing on their own within 15 to 30 seconds after birth. If it's the longer end, it could seem like a lifetime. Heart rate below 120 is not sufficient. So resuscitation and assessment. Gently tap or flick the soles of the feet or rub the back. Newborns require some form of stimulation. Position the airway, drying, warming, suctioning, or tactile stimulation. Generally, rubbing the baby to get all that cottage cheese off is a good way to stimulate it. So here's some resuscitation pointers. Should take a close look at this. Position the newborn on his or her back with the head down and the neck slightly extended. Suction the mouth and then the nose. We generally need to suction at least the nose. We should take a close look in the mouth and seriously consider it. Drying the head, back, and body with dry towels. Rub the back and flip or slap the soles of the feet. Very effective at stimulating the baby. Observe the newborn for spontaneous respiration, skin color, and movement. Remember, the extremities will most likely be blue or mottled. That's normal when they first pop out. Evaluate the heart rate at the base of the umbilical cord or brachial artery, or by listening with a stethoscope to the heart. Heart rate is the most important thing. We need to make sure that it's super fast. So here we go. Below 100, we are going to, that's more, 60 to 100, assist with ventilating. We're going to try to hyperventilate the patient a little bit. Breaths every 3 seconds, 3 to 5 seconds. And less than 60 breaths, you're doing CPR. Use hand encircling technique that we learned at the very beginning of your class in CPR class. BVM ventilation during a pause after every third compression. So we're going to do a lot of breathing and compressing. More than routine resuscitation, need a neonatal ICU. 12 to 16% of deliveries have meconium or poop present. Suction the mouth and nose to get rid of that meconium and then provide rescue ventilations. So the APGAR score. We need to do this at 1 minute and 5 minutes to start. A number valued to 5 areas: appearance, pulse, grimace, activity, and respirations. The total of the 5 numbers is 10 at best. 1 minute and 5 minute intervals after the birth. So here's your chart. You should know this for your testing purposes. It would be really great if you just know it, but nobody expects you to. This is something that is available in your charting software. But you should know all these things at 1 minute and 5 minutes. Even if you don't give it a numerical score right away, you still want to make a note of how they are. Calculate the APGAR. Stimulation should result in an immediate increase in respirations. Heart rate and respiration should both go up when you stimulate the baby. If breathing looks good, then move on to check the pulse. Assess oxygenation with a pulse oximeter and observe for central cyanosis. So again, we're not concerned about peripheral, about the extremities being cyanotic. We are concerned with the trunk being cyanotic. Second unit, you really request a second unit if it looks like you're going to deliver on scene. Get some more help there. Using newborn BVM, which is, it looks like about the size, perfectly round and about the size of a $50. If the newborn does not begin breathing on his or her own or does not have an adequate heart rate, continue CPR and rapidly transport. That is very good advice. A breech baby means it did not rotate. The head is not coming out first. It takes longer. You will often have time to transport the pregnant woman to the hospital. If the buttocks have passed through the vagina, the delivery has begun. Emergency care, call for ALS backup, consult medical control to find out what you should do. Basically, it's the same as normal childbirth. To prepare on scene, allow buttocks and legs to deliver spontaneously, supporting them with your hand. The head is almost always face down, should be allowed to deliver spontaneously. Mark a V with your gloved finger. Make a V around the face to protect the airway. Presentation complications. A limb presentation is a problem. They need to be cut out of mama. You need to transport fast and furious. Cover it with sterile towel. Keep mom and baby's leg or arm warm. Never push on it. Never pull on it. Patient on her back with the head down and pelvis elevated. Prolapsed cord must be treated in the hospital. Umbilical cord comes out of the vagina before the fetus. That's a prolapse. That's a problem. Fetus's head will press on that cord. Do not push the cord in. Patient, again, supine, raise the foot end of the cot, elevate her hips in the knee chest position. So really get her knees up to her chest. Insert your hand into the vagina and push the fetus's head away from the cord. Transport rapidly with your hand there. Your hand is there and it is staying there until the baby is cut out of mama. So by all means, pick the new guy, them perform that procedure, and then once their hand's in, make sure they know that their hand's in until the very end. Spina bifida is a whole nother monster. The spinal cord protrude outside the vertebrae. If this happens, cover the open area with a sterile, moist dressing. Keep the baby warm. Maintain body temperature is important. The best place for this child is on mom. Right on her chest and wrap them both up together. Twins, I feel for you, the provider, and for mom, and for dad. They tend to be smaller, but not difficult because, again, they're smaller. They're going to come out easier. About 10 minutes break, and then the second one should start. Same procedure as a single one, except you're going to do it more than one. There may be one or more placentas. We wouldn't know this. Prenatal care would tell mom whether it's one or more. Twins may be so small they look like preemies, but they're not. Handle carefully and keep them warm. Weight about 7 pounds. It could be north of that or south of that. Before 36 weeks and weighs less than 5 pounds is considered premature. Preemie is smaller, it's thinner, it's not proportionate, less body hair. Preemies require special care. Resuscitation efforts, which should be performed unless it is physically impossible. Preemies as small as 1 pound have survived. Preemies as early as 16 weeks have survived. So we need to really do everything we can. Post-term pregnancy, no woman wants this, no husband wants this. Fetuses could get larger than 10 pounds, can lead to lots of problems. Most doctors will cut the baby out long before, or induce natural birthing long before 42 weeks. So injury to the fetus, likelihood of cesarean. Perinatal tears are almost guaranteed. Post-term newborns have increased risks of poop, aspirations, infection, and stillborn. Newborns may not have developed normally. You don't want babies in mom that long. Fetal demise, stillborn is what we tend to call it. Premature labor, but it looks like it progresses normally, or most of the time it will progress into a full term. Intrauterine infection caused the demise. You may note a foul odor. Do not attempt to resuscitate an obviously dead newborn. Delivery without sterile supplies. Do it. We've been having babies for thousands of years. Eye protection and gloves and a mask with you. You should have those in your kit your first responder kit. Carry out delivery as sterile as possible. Use whatever you could get. Freshly laundered sheets, towels, whatever's on hand. Clear out the newborn's mouth with your finger. Do not cut or clamp the umbilical cord until you could do so with appropriate equipment. Wrap it in a clean towel and transport with the baby attached if you have no other option. Keep placenta and newborn at the same level and keep the newborn warm. You need to make sure that the placenta doesn't, or all the baby's fluids don't drain out of the baby. Postpartum complications. Massage that uterus to the best of your ability. Check your technique and hand placement. If bleeding continues, excessive bleeding is usually caused by the uterine muscles not fully contracting. Placing baby to breast and massaging is the best solution. Cover the vagina with sterile pads. Change them as often as possible or as necessary. Do not discard. You want to keep them all. They're going to want to squeeze them out and collect all the blood when you get to the hospital. I'm joking. They weigh them. Administer oxygen, monitor vitals, and transport as soon as possible. Postpartum, you're at an increased risk for embolism. Generally, it becomes a pulmonary embolism from a clot that travels, just like any other pulmonary embolism. Sudden difficulty breathing or shortness of breath following delivery is probably a pulmonary embolism, which is a problem. All right, that's it. The next 40 slides are review that I don't want to do. So again, if you want to hit all the review questions, please go to the comprehensive slides in your chapter tab and navigate to and work on through them. Get in touch with me with any questions. Thank you for watching, and hopefully we could get back to real class someday soon.